I'm Dr. Frank Yeli.
Hi, I'm Dr. Edward Dourron.
Hi, I'm Dr. Lee Cao.
So today we'll talk about the diminished ovarian reserve. How about starting with Dr. Dourron?
Well, diminished ovarian reserve is a term that's been used of late to describe patients that have a low quantity of eggs. And it's often correlated with age, so that patients as they get older, they tend to be labeled as having diminished ovarian reserve. The way the diagnosis is made is primarily through hormone blood testing. So there's the FSH, or follicle stimulating hormone, which is tested along with estrogen to give an idea of diminished ovarian reserve. There's also anti-Mullerian hormone, which gives us an idea of diminished ovarian reserve. Together with an ultrasound, which gives us a good picture of the follicles that contain the eggs in the ovaries, we get a good picture of what the patient's egg production potential is. Dr. Cao, what's your thoughts on diminished ovarian reserve?
Well, as I usually sort of describe for patients, you want to think about ovarian reserves just like how much more gas you have, left in your car's, gas tank. Usually there's a mechanism of gauging it. It's not very accurate, but it gives a general estimate, which is a good prediction. And like what Dr. Dourron, you just pointed out, usually there are three things we use. One is at the FSH level, one would be the AMH level, and the other, of course, will be visually by ultrasound estimation.
So what do you think of the cause of the diminution of ovarian reserve?
Well, I think we need to point out a distinction between premature menopause and diminished ovarian reserve. So there are a very small percentage of patients that do enter into premature menopause, which is often called premature ovarian failure. And what happens in their case is that there's often an autoimmune reason that their ovaries are attacked and that they go into menopause often before the age of 35. And that's the definition of premature ovarian failure. So that's a small group of patients, and that really doesn't fit in with what we call diminished ovarian reserve, which is for patients as they get older and are now considering having children, that their reproductive potential is diminished. And what used to happen is everybody's family would be complete by age 30, and that women would have this diminished ovarian reserve at age 35 or 40, but since they weren't trying to get pregnant, it was not apparent. So I really don't think that there's anything in the diet environment that's changing the ovarian reserve of women. I think it's primarily delaying childbirth.
So if you look at the reproductive whole lifespan, right, you started with plenty of oocytes, and at some point you're going to exhaust them. And the general sort of cross-section that we've been looking at, like earlier you pointed out, people used to be having children at a much younger age, and now we're just sort of moving that whole reproductive span further down the road, and we're going to see a lot more, quote-unquote, diminished ovarian reserve patients.
So in addition, just for the age factor, and also actually the cause of genetic components also play a role, and some women just for genetic disposition for the more easy to develop diminished ovarian reserve. So in addition to that, and also some of antibody immunological factor, and the body produce antibody against the ovarian tissue and against the thyroid tissue. So patients with multi-organ of endocrine failure or endocrine disorder tends to have an increased risk of diminished ovarian reserve. So in addition to that, and also the gynecological factor also play a role. For example, woman has severe endometriosis, and because of developing multiple endometrioma, and eventually of patient, I have seen quite a few patients of that patient also develop diminished ovarian reserve. Lastly, and also I have noticed of some of medical treatment for patients with either chemotherapy or radiation therapy, and or even just for surgical treatment. Some people just multiple surgery to remove the uterine, the ovarian cyst, and this also causing diminished ovarian reserve.
Right, definitely. And one of the things here, where we are in California, we don't see as much, but need to bring it up that smoking has been very, very well documented throughout the whole medical literature. That has a significant impact on ovarian reserve and reproductive capacity.
Now that you have a patient where you've identified this problem, especially in patients that are younger than 40 years of age, what's your suggestion to them in terms of preserving their potential to have a family? Some of these patients are diagnosed with this when they are not in a relationship, and they feel like they're pressured to make a decision about what to do to preserve their reproductive potential. Mm-hmm. What are your thoughts?
Yeah, first of all, I think this issue is under diagnosed because many people with diminished ovarian reserve, they usually don't have symptoms. At least they are going to see doctor to do regular physical examination and check her hormones and doing ultrasound. Otherwise, she probably will not find out she has diminished ovarian reserve. So obviously, when the patient already develops symptoms, starting her irregular period, shortening her cycles, or starting getting pregnant to difficult to resolve pregnancy, for those patients already at the late stage of the diagnosis of diminished ovarian reserve. But in general, if I would encourage all of those women, and even they are not actively try to conceive, I would still suggest them to do the regular checkup and especially check their hormone level and to see if their ovarian function, how is their ovarian function. It's easy. You can check her ultrasound by check E2 level, FSH, LH, progesterone, and or AMH. We can easily find out whether woman has this kind of issue or not. So, but if we do find out the woman has diminished ovarian reserve, and for those women, if they are already married, and I would strongly encourage them to try to moving forward to having babies sooner. So then we can help them to banking some egg or banking some embryos. And even if they are not ready to have a baby right at that moment, we can always freeze some embryos for the future because they already have a signs of diminished ovarian reserve. I don't want them to delay too much and that time when the children develop a premature ovarian failure, then it will be difficult to help them conceive. But for the woman and has not married yet, and for those women, we strongly encourage them to freeze their eggs, and so when they do get married, they have a frozen egg can be utilized for the future develop have the child.
Yeah, that makes a lot of sense. I've even heard of women getting together, single women, and having egg freezing parties, where part of that process may be that they have an ovarian reserve checkup to find out what their status is. Because like you said, it's something that women don't generally have symptoms. Oftentimes they can look at their mother or other family members if they underwent, like you mentioned earlier, menopause at an earlier age, let's say age 40, then certainly it puts her as a daughter at risk for having diminished ovarian reserve or going into premature menopause. And now with the ability to freeze eggs, that really gives patients a wonderful option where they don't feel pressured to either select a partner or a sperm donor and form embryos.
Yeah, I totally agree with that. In general, I think it is a good idea, especially if you're age above 35. Nowadays, the technique in the cryopreservation is so much more better, and as far as I know, a lot more insurance companies are offering that as a part of their coverage. So, definitely, though we sort of more on the intellectual side, on the medical side, we're talking about all these prediction factors, but I think in general, if someone who's age above 35 probably should just have a little in-depth discussion, with reproductive endocrinologists at least.
There's severity of diminished ovarian reserve. Some of just mild reduce of ovarian reserve, and some of more severe diminished ovarian reserve. For those two different category patients, and at the Life IVF Center, how we help those women to, in terms of produce, either using the methodology to produce the follicle and the freeze egg, or using the IVF monitoring, and then to help them banking some embryos. What kind of protocol would you guys using?
So, what's important to understand is that patients that have diminished ovarian reserve, in general, are going to have elevated FSHs. So since they have elevated FSHs, their pituitary is already sending the follicle stimulating hormone to the ovary, and all the receptors are saturated. So the ovary is getting as much gas, let's say, from follicle stimulating hormone as it's going to get. So giving them fertility medication in the form of gonadotropins, FSH, is not effective. So that's the first thing to understand. Secondly, we have strategies where by giving them estrogen, knowing that estrogen will lower the FSH level in the pituitary gland, we can artificially suppress the FSH level that, especially in women that are under 45, may allow a follicle or two to start to develop. And by keeping the FSH level down and giving them that estrogen, all it takes is monitoring, which we do, every 4 to 7 days to see how the follicle's progressing, and you have to be patient. You can't pull the plug after 7 days and say you're not going to grow an egg. You have to be patient, and we are very successful at these patients to have them to tease the ovary to grow an egg. So what I just illustrated would be someone that has a very high FSH, what we would call a severe diminished ovarian reserve, or someone that's even on the verge of menopause. For other patients that have mildly elevated FSHs, those are patients that can be treated with medication like Clomid or letrozole to try to have them produce more eggs. Giving them FSH typically isn't helpful, but giving them medication like Clomid or letrozole can help them, often produce 3 to 5 eggs, which is great for their situation, because that's probably as many or more than they would have produced on the maximum dose of fertility drugs. Any thoughts?
Yeah, I totally agree. Other than the FSH, right, several years ago, one of the big groups published this, predictive model, let's put it that way. They were saying that based on their experience, if someone's baseline FSH is above 19, basically her chance of using conventional IVF becoming pregnant is 0. If they're above like 15, then it's very, very minimum. And I'm sure, we have a lot more experience, in those people who have achieved success. Other than FSH, coming back to AMH, the literature in the past has suggested if someone whose AMH is under 2, right, the review suggestion that if they going through conventional IVF, they probably will retrieve no more than 6 oocytes, and whose AMH is under 1, then they probably will have no more than 4 oocytes. So that again, shows that, just like earlier what you said, these people, their ovaries either have limit or their receptors are saturated, so the conventional IVF most likely is not going to do well. And the most recent review just came up a couple months ago. It certainly, corresponds with that.
Yeah, we see so many patients have so-called diminished ovarian reserve, like when you say FSH level above 20 and or AMH level below 1. And I see so many patients was recommended by their IEI doctor to suggest them using donor egg. So I often feel so bad for those patients, because I believe many of them really don't necessarily to using donor egg. And I see those patients choosing donor egg by their doctor's recommendation prematurely. So I just give you one example. And recently we had a patient from UK, and so she is a 40 years old woman, and her FSH level was vary between 20 to 24. And her AMH level was 0.01. So her doctor in UK would suggest her using donor egg. So when she came to us and we did a natural cycle IVF for her, because her FSH level are high, as you pointed correctly, we don't have to give them medication because all the fertility drug will raise her FSH level. So her FSH level already high. You cannot give FSH levels even further. So the patient was choosing natural cycle IVF, and we finished 3 natural cycle IVF for this patient, and we actually get 3 eggs, made 3 embryos, and 2 of those 3 embryos passed PGS test. And the first embryo transfer results pregnancy. So this is just one typical example. So if this patient, if she came in and we using conventional IVF and give her the Ghana F 300 and the menopause 150, and I think her F should be raised to about 45 or 50. So then I think this patient have no chance follicle will grow. So sometimes I always give example and use medication to promoting follicle growth is just almost like a growing flower give fertilizer. Not always the more the better. So if you put too much fertilizer there and the flower will be burned. That's a very similar concept.
And that example points out a very important point that we touched on earlier, which is that the egg quality is not associated with the FSH. So although the patient had a very elevated FSH and was told that she needed to do donor egg, which in her mind may be telling her your eggs are no good or you don't have any left, the reality is that she's like any other 40-year-old, and when she makes an egg, she has the same probability of it being normal in the form of an embryo and PGS testing. So in her case, her eggs actually performed better than a same person, her same age, because that was remarkable to have 2 out of 3 embryos come back genetically normal. That's more like an egg donor. So that's a perfect example of how the genetics of the embryo, the quality of the embryo, and how or of the egg and how it performs really doesn't correlate to her diagnosis of diminished ovarian reserve.
Yeah, I just sort of, as you were describing those, I'm thinking about, right? So conventionally, why do infertility doctors recommend patients to consider doing donor eggs? Part of it, I think the rationale came from the financial perspective, right? Because if you're going to do conventional IVF, you're going to use huge quantity of medication, and back in the older days, none of this would be insurance cover services. So in relative ways, sort of donor oocyte would be a lot more achievable, let's put it that way, financially make more sense to patient. But in our setting, this will be slightly different because our cost will be a lot more reasonable, and people are able to do multiple cycles, and they don't need to spend so much money to try to stimulate the ovary, which eventually do not respond. So it actually makes trying to have their own oocyte generate embryos make a much more reasonable alternative.
Well, because it costs less than donor egg IVF.
It actually ended up costing much, much less.
Yeah, I think during our fellowship training, and we always was told, and if during conventional IVF, if less than 3 follicle grow, we have cast the cycle. Right. So for those patients, you have no way to grow in 3 follicles. It's 1 follicle, that's it. So I think with natural IVF, that's certainly give this patient a chance. So although donor egg is an option, is a good option, but for certain patients, but many patients, especially in our community and many Asian origin, and they feel very strongly and they want to have their own biological child. So for those patients, if you easily push them using donor egg, they have very strong resistance. So I think for those patients, we really have to give them a chance.
And I think one thing that's important is that, especially for someone that's 40 or 42 and has a diagnosis of diminished ovarian reserve, natural cycle IVF is something that they can pursue now that's going to offer a better chance for pregnancy than it will 2 years from now. The success rate from donor egg treatment for that couple will never change. It's going to remain the same even if they waited 5 years to do it. So that it's really seizing the opportunity when you have the highest chance of being successful with your own eggs and knowing that you can do that without breaking the bank. And if that is unsuccessful, then you always have the option of donor egg down the road.
Right. And one of the things I would like to add on to part of our discussion is earlier what you pointed out, right? Conventionally, if we don't have 3 or 4 follicles, we just will cancel the retrieval. And is attributed to the risk of the procedure, the risk of anesthesia, but that's not what we do here. Our patients, we use different needles, and just about all our patients do not undergo anesthesia. So that risk-benefit ratio totally gets turned around. So makes our protocols, a lot more reasonable in that scenario.
So I would like to summarize of today's the discussion. And dementia ovarian reserve is a very common medical condition, and many women suffer this condition. And also those women, and very often to be told by their doctors, because your FSH level too high, your AMH level too low, and you have too few follicles, and recommend them using donor egg. So I really think you should think again, and for those women has been strongly encouraged by your doctor to do donor egg retrieval because of you have a dementia ovarian reserve. Please give a second thought, and if you have a chance to call us, and we have be happy to give you a consultation and review your system and review your condition to see if we can help you to achieve pregnancy with your own eggs.